مطولين عليكم. نتمنى بس ان احنا نكون ضيوف خفاف، الا وهي سيشن الشيست ايميجنج. النهارده هنقوم بجوله كده along اللونج سكريننج بروجرام، من اول النديول ديتكشن لللونج سكريننج ريبورتنج والرول اوف بات سي تي والرول اوف اي اي. كل القصه ان شاء الله تكون مكتمله النهارده، ونبتدي باستاذتنا الدكتوره ايمان على الدياجنوزس بتاع البلمونري نديول.
مساء الخير جميعا، ويعني شاكره جدا للدعوه للمؤتمر. التوك بتاعتي هتبقى Diagnostic Dilemma of Pulmonary Nodules. Pulmonary nodules are a very common daily finding in our practice, and always we have the problem of deciding whether they are benign or malignant, how we will proceed with them. We see them in every single CT chest, even in the CT abdomens, in the CT cuts of the lower chest. And the problem is, if we decide they are benign, we will tell the patient that they do not need any further workup, and if malignant, it will be a different case. For proper management risk stratification should avoid unnecessary investigations and avoid causing an anxiety to the patient. By definition, pulmonary nodule is an opacity less than 3 centimeters surrounded by aerated lung, not reaching the hilum or mediastinum. The vast majority are very small, sub-centimetric and less than even 3 millimeters. However, the suspicious one, or the one that will develop later on lung cancer, it's very important to detect it, since it will make a great difference in the management of the patient in early treatment. As we know, lung cancer is the most fatal worldwide. Vast, huge differential diagnosis for lung nodules, benign, whether benign or malignant, infections, immune-mediated, congenital. Before we start dealing with whether they are benign or malignant, we have to make sure that the CT technique is proper, thin sections in full inspiration. We manage usually from lung window and go to the mediastinal window for side findings. The MOHP helps a lot in the pulmonary nodules, and of course, as will be mentioned later in the screening, low-dose CT. The items that we should look for to decide whether they are benign or malignant: the size, the growth or stability. And in this case, it's very important to look for old investigations, old studies if possible, calcification patterns, the density, the margins, the location, and internal characteristics as air bronchogram or cavitations. Some benign features, if found, then we are cool, and the patient does not need any further workup, as typical calcification patterns, complete calcification, central, peripheral, popcorn, or laminated. The presence of fat is also a very benign finding, as in this case we have a nodule with calcification and fat, diagnostic of hamartoma, and nothing further need to be done. Central or laminated calcification in granuloma, also nothing needs to be done. Stability, if for 2 years, then we are in benign spectrum. The small nodules, the smaller ones, are nearly totally benign, and the periphyseal nodules with the typical features, fissure-based, triangular or oval-shaped. We only get suspicious with the periphyseal nodules if they cross the fissure. Alarming features start with the history. The older the age, females are now equal or more affected than males. Race, history of extrathoracic cancer within the last 5 years, family history, smoking, and other inhaled carcinogens. Also, emphysema or fibrosis increase the probability of malignancy. Size, as we go over 8 to 10 millimeter, it's more towards malignancy. Eccentric calcification patterns, speculated margins, the growth, we will talk about it later, and the upper lobe location. Size matters. Starting from 8, we get suspicious, and as the lesion increases in size, the probability of malignancy increases. All studies, whether the Mayo Clinic that said that 0% in the nodules less than 4 millimeters, 0.8 in those 4 millimeter, and 7 were malignant. The Fleshner study, the Fleshner Society, the British Society of Radiology, all of them, they decided that the threshold of the size was 6 millimeter and 8 millimeters. However, there are exceptions. If we look at these three images, we will say from what I said before that a 0.2 centimeter is benign and the other two are suspicious. However, metastatic nodules are very deceiving. They are smooth, they have smooth outline, and they are very small. So the smallest one was metastatic, and the larger one, the ugly one, was granuloma, all TB, and the middle one was squamous carcinoma. So we always have to put in mind exceptions. How to measure the nodule is very important. We have to measure it in lung window. Take the longest axis, usually in the axial cuts, and approximate it to the nearest millimeter. If we have larger nodules, then we take the average of the short and long axis. And those larger than 1 centimeter, then we take the short and long axis and use the long axis in the T staging. And as will be discussed in the lung screening, we sometimes use a volumetric assessment with certain softwares. The volume doubling time is the most common used parameter for estimating the rate of growth. We consider it stable, as we said, if it's stable for 2 years, and the range is from 20 to 400 days. And we consider it increased if it increased for 25% or 26%. However, the ground glass nodules grow very slowly, and so they need longer follow-up. For example, very suspicious nodule, speculated outline. And here comes the benefit of the old studies if present. This study was 3 months before the one with the nodule. So if this is a very rapidly growing lesion, then we go for benign probability more. 3 months later, it was nearly resolved. The densities are either solid or subsolid, whether part solid and part ground glass, or pure ground glass nodules. The solid could be benign or focal scar, lymph nodes, primary malignancy, or metastatic. While the subsolid are usually infection or inflammation or hemorrhagic, and they are usually transient, or could be neoplastic, and this is the crucial one, lying within the adenocarcinoma spectrum. There is no reliable distinction. The larger the size and the larger the solid component, or the presence of a newly developed solid component, makes it more probable, makes the malignant probability more. The subsolid lesions have slower growth rate, but higher risk of malignancy. And this is why, and persistence also increases the probability of malignancy. This is why we have to increase the follow-up interval for these lesions. Example for a benign transient ground glass nodule, 3 months, and then later on it totally resolved. Another nodule that increased in size after 2-year interval. So the follow-up period for the ground glass ones, we should extend it to 5 years. 3-month follow-up interval showed increase in the solid component. So we are towards malignancy. The same increase in the size of the lesion in general, the solid and the ground glass component, and also the solid component more, with an interval of 15 months and then 10-month interval. Suspicious lesions with ill-defined outline, yet the follow-up showed total resolution. And another lesion that was focal infection and also total resolution. The rate of malignancy in the subsolid with ground glass components is 63%, in the ground glass 18%, and in the solid 7%. So the ground glass component is very tricky. Another feature is the air bronchogram, which we usually see in the benign lesions as pneumonia. However, we can see it also in non-invasive adenocarcinoma or lymphoma. Calcification pattern is eccentric or amorphous. And the margins, as we all know, is the speculated margins or the corona radiata. And as we said before, the smooth ones are only in metastatic deposits. The location also is important. The upper lobe are usually malignant. The periphery and the perihilar could be secondaries or adenocarcinoma, and the periphyseal intrapulmonary lymph nodes. This is a case of bilateral multifocal adenocarcinoma. Other internal characteristics are cavitations, and we have here to look properly at the margins of the cavity. The thin margin is more towards benign, and the thick margin, irregular, is more towards malignancy. Very wide range of percent. And before leaving the possibilities, we have always to put in mind that vascular nature should be in our mind to avoid unnecessary intervention. In case we suspect that there is a feeding vessel or any lobulated outline that could be vascular, we have to proceed to post-contrast or further investigations before going to an invasive one. All the decision-making of whether this needs follow-up or not should be a shared decision in an MDT between the radiologist and the clinician. We should talk the same language using the guidelines that are present, like Fleshner Society. The last one is 2017, or the British Thoracic Society guidelines. Of course, the lung RADS, as will be discussed later, is concerned mainly with the lung screening programs. Fleshner, they divided into a single or multiple, and the single, whether the patient has a high risk or low risk. And as we said before, the threshold of size is between 6 millimeters, mostly benign, 6 to 8 or more than 8, and the follow-ups accordingly. The subsolid also nodules, whether single or multiple, and here whether ground glass pure or partly solid. Exceptions to these guidelines: if the patient is younger than 35 years, if he has a known primary malignancy or immunocompromised, or that the study itself was insufficient, whether thick slices or the scan was incomplete. Thank you for listening.